You can also continue the conversation, the same conversation, but just summarize the paper, the results, but also mention if there was anything objective measured from the one patient. I don't think there was, but we just need a confirmation. But it's might do just the last review. And if you have checked BioniChaos.com and you have any questions, do let us know. With this PPG monitoring, this is obviously synthetic. I don't know if I have to say. Well, I mean, it could be real data as well. So you wouldn't know, would you? Would you? This is also based on a paper results that essentially say that how the position of your body, so if you're standing, sitting, lying down, it changes PPG recordings, so your blood oxygenation recordings. So this is obviously approximation of what was in the paper. Oops. When you sit, you can do arm on the lap or arm on heart. Makes a difference. Yeah, obviously the cartoon is not great, but you get the point. Yeah, so for example, if you're standing up and you hold your arm at heart, you get a much stronger signal. When you have your arm down, yeah, you get a lot of noise and things. So this is results from this paper. We actually split the result into two sections because they're also talking about how age changes your PPG. I won't be trying to pronounce PPG, but yeah, Photoplethysmography. How did I go? Any Latin native speakers listening to this? Do let me know. Yes, because we do want to collaborate with clinicians. So the rest of the paper, so essentially we split the results of the paper into two. One is the standing position, sitting down, lying down, whatever, how it affects the signal to noise ratio of blood oxygenation measurement. And that one is your age, skin tone, and obviously the lead intensity, which doesn't seem to make much difference in this case, even though I'm a bit suspicious of it. But yeah, it's just an approximation of the results from the paper. I mean, it's still better than looking at the graphs they have in the paper itself. So yeah, if you have any feedback on this, I'll pop the two tools links, whatever they're called, visualizations, animations. What are they also called? Interactive. Well, they are interactive. I'll pop the links in the chat. Let me know what you think. Funny enough, if you ask in person, someone, do you prefer my voice as opposed to AI? They always say we prefer your voice, but currently I can tell for sure that data is showing otherwise. That you actually do, that viewers do prefer AI talking. Well, probably because they're just doing it much better. Yeah, so we're reviewing this paper. I have this implant that one patient have received. Anyway, obviously no one's actually reading papers. I was reading text, but we had a chat, a very detailed chat to, in this case, Gemini, and we turned that discussion we had into a conversation between neuroscience expert and biomedical engineer, which will start playing whenever AI Studio is finishing generating.
A clinical neuroscientist and psychiatrist specializing in treatment-resistant depression and neuromodulation.
a biomedical engineer focused on closed-loop neural interfaces and computational modeling. Anya, let's get right into it, the PACE paper. From an engineering standpoint, it's a masterpiece of system integration. The PFM-guided targeting, the cortical paddles, and the adaptive optimization, it's the full closed-loop blueprint we've been theorizing about for years, actually implemented. The elegance of the Bayes tuning is what really stands out to me.
I agree it's an elegant blueprint, Ben. And the clinical outcome is undeniably spectacular for this one individual. But my clinical skepticism kicks in precisely at the point of that elegance. The system is only as good as its inputs, and the inputs here are profoundly problematic. We're not just optimizing a circuit, we're optimizing a person embedded in a high-expectation clinical trial.
Let's break that down. The optimization target was the composite score, f of x, which incorporated sleep, mood, and preference. The beauty of the Bayesian optimization, specifically the Gaussian process regression model, is its ability to intelligently map that response surface without exhaustive searching. It balances exploitation of known good parameters with exploration of uncertain regions. It's a data-efficient solution to an n-dimensional parameter space problem.
And that's where the critique begins. The objective function f of x is a black box of subjectivity. The mood and sleep metrics were standardized by z-scores relative to baseline, which is fine, but the heaviest weight, the one that can truly differentiate closely performing settings, is the patient's subjective preference ranking. The paper shows that stimulating the DMN contacts produced immediate, overwhelming joy. Stimulating the FPN produced clarity. These are potent acute hedonic effects.
You're suggesting the algorithm wasn't optimizing for a durable antidepressant effect, but rather for a transient, desirable sensation.
I'm suggesting that the algorithm is, by its very design, incapable of telling the difference. A patient suffering for 30 years is given a setting that produces a novel feeling of euphoria. Of course they will rate that a 10 on preference. The algorithm, doing its job, will then aggressively search the parameter space around that peak. The system could be inadvertently selecting for a setting that provides a rewarding jolt, which is not necessarily the same as a setting that normalizes network function and provides stable euthymia.
That's a powerful point. The model's optimizing the proxy, not necessarily the underlying pathology. But the sham-controlled videos seem to argue against a pure placebo effect. The anxiety response to stimulating all contacts simultaneously, which subsided with sham and returned upon restarting, suggests a very real, non-placebo physiological mechanism.
Absolutely. I don't doubt for a second that the stimulation is causing direct, network-specific neurophysiological effects. The issue isn't a classic placebo, where an inert intervention works. It's a far more complex scenario, an active intervention whose perceived benefit is massively amplified by expectancy, and that amplified perception is then used as the primary input to guide the therapy itself. It's a confounding feedback loop. The patient's CEQ score jumping from 30% to 90% is a flashing red light. The Bayes tuning algorithm is essentially chasing a signal that is a mixture of genuine effect and powerful psychological context. We can't disentangle them.
So to improve the system, we need a more objective biomarker as an input to the objective function, something like a specific spectral feature from a local field potential or a wearable derived measure of activity or sleep architecture to replace or supplement that subjective preference score.
Exactly. Without that, the rigor of the algorithm is undermined. Which brings me to the data itself. I was frustrated by the lack of transparency. The paper presents a compelling narrative, but the quantitative evidence is heavily processed.
What do you mean? They showed the outcome scores over time.
They showed smoothed curves. The paper explicitly states they fit the HDRS, MADRS, and MSSI data with a smoothing spline because the raw weekly scores were too volatile to accurately capture changes. As a clinician, I want to see that volatility. I want to see the raw daily mood and preference scores that are fed to the PR. Without that raw data, we can't independently evaluate the optimization process. We can't see if the algorithm converged smoothly or if it jumped around based on fleeting patient preferences. All we have are curated video snippets and a curve fit with an R-squared of greater than 0.9. It feels more like a presentation than a dataset.
I can see that. From a reproducibility standpoint, the raw time series data from the optimization phase would be critical. It's likely a limitation of the N of 1 case study format, but it's a valid critique. What about the core biomarker they targeted, the expanded salience network?
It's a fascinating finding. But again, N of 1. Is this massively expanded SN the defining feature of ultra-treatment-resistant depression? Or is it an idiosyncratic feature of this one patient? They even show in Figure 1D that this brainotype isn't universal. This success might only be applicable to a tiny, uncharacterized subset of the TRD population. Calling the approach scalable in the abstract feels premature at best.
I'd argue the scalability isn't about the specific biomarker, it's the methodology. The blueprint is scalable. PFM to find any individual network anomaly, targeted simulation to modulate it, and Bayes tuning to optimize it. The target might change from patient to patient, but the process remains. Of course, the resource cost is immense right now, but that's a technology maturation problem, not a fundamental flaw in the concept.
It's a fair point, but for now, we have a single, remarkable result from a study with significant potential confounds, guided by an elegant algorithm operating on subjective, unauditable data. It's a phenomenal proof of concept, Ben, but it's not a validated therapy. It's a starting gun for a decade of incredibly difficult work to see if this can be made rigorous, objective, and truly generalizable.
Agreed. The next iteration needs objective biomarkers for the optimization loop, and the next trial needs a larger cohort to validate the SN biomarker. But you have to admit, as a starting gun, it's about as loud and brilliant as they come.
On that, we are in complete agreement. Now, let's talk about the specific choice of a Gaussian process model. I have some thoughts on its kernel selection for this type of noisy biological data.
Okay, I'm with you. Let's get into the weeds. They don't specify the kernel in the paper, which is an omission, but I'd bet my next grant they used a standard squared exponential kernel, probably with automatic relevance determination for the different parameters. It's the default for a reason. It assumes the underlying function is smooth and infinitely differentiable, which is a robust and reasonable prior when you have no initial information about the patient's response surface. You have to start somewhere.
And that's precisely where my clinical intuition raises a red flag. That assumption of smoothness is a mathematical convenience that may not reflect biological reality. Ben, a patient's neurophysiological response isn't a gentle, rolling hill. It can be a landscape of sharp cliffs and narrow peaks. Think about it. What if there's a specific frequency, say 70 Hz, above which a critical population of inhibitory interneurons is recruited, and the therapeutic effect doesn't just diminish, it drops off a cliff? A standard RBF kernel would struggle to model that sharp discontinuity. It would try to smooth over it, potentially misidentifying the true optimum, which might lie right at the edge of that cliff.
So you're proposing a less smooth prior, a May-turn kernel, perhaps, one that assumes the function is only k times differentiable. That would allow the model to represent a more jagged, less idealized response surface.
Exactly. A May-turn 3/2 or 5/2 would be a more biologically plausible starting point. But the bigger issue is the assumption of stationarity. The model assumes the response landscape is fixed over the entire 6-month optimization period. But we are actively stimulating the brain. The very purpose is to induce plasticity. The patient might develop tolerance to a specific frequency, causing a peak that was prominent in month 2 to flatten by month 5. A stationary kernel is blind to that temporal dynamic. The optimal setting it finds is a snapshot, not a moving picture.
You're right, of course. A non-stationary kernel could, in theory, model how the hyperparameters of the response surface change over time. But the data requirements for that are immense. You'd need far more than 5 test points per month to reliably model not just the landscape, but how the landscape itself is warping. With an N of 1 study, they were already data-starved. Opting for a simpler stationary kernel was likely a pragmatic trade-off between biological accuracy and the very real risk of overfitting a more complex model to noise. It's a classic engineering compromise.
A compromise that we need to acknowledge when we interpret the stunning success. They found a stable setting, but we don't know if it's truly the dynamic optimum.
Exactly. And for all our deconstruction of the methodology, the kernels, the current spread, the subjective inputs, we do have to keep returning to the ground truth of the clinical results. They were, on paper, staggering. Let's just recap them.
Go ahead. It's important to keep the outcome in focus.
Right. The patient's MSSI score for suicidal ideation, which was a moderate 15 at baseline, went to 0 within 7 weeks and stayed there. That alone is a life-saving intervention. The primary depression metric, the HDRS-24, dropped from a severe 27 to 11 by 4 months, just shy of remission, and then hit 8 by 9 months.
Yeah, I should try to see where did it stop. I think we went over this paper in quite the length. So essentially N of 1, so one subject, a highly subjective, essentially modifying stimulation parameters based on these responses from the patient. I feel calm, relaxed, not overwhelmed. They're very different anyway, very similar anyway, the responses. So how many electrodes did it have? 4? There's a plant and placement, so the 4 looks like they're a bit different from the plant placement. We have four of these electrodes. Doesn't look like we have an electrode over there based on this image. Want there more electrodes? Yeah, very low res MRI. I suspect because the electrode array might not be safe in a stronger MRI, in a stronger magnetic field. So it'll fly out of the patient's head. But yeah, we did actually place the comment about the strong placebo, the potential of a strong placebo effect to the author. Did we have a response? No. Okay, let's move on.